I request Dr. Sushil Kodali to kindly come up, and he is going to speak about left atrial appendage closure, which is superior to medical therapy for atrial fibrillation.
So I'll try and get going and move quickly here. I'm sort of filling in here, and the slides are up there. Special thanks to Saibal Kar, who usually comes to this meeting but couldn't come this year, and who helped provide me some of the slides. I'll go through the background quickly. Everyone's familiar. The ischemic stroke is the most common complication of AFib. And we know that anticoagulation with antithrombotics shows a reduction in ischemic stroke, but they have issues: compliance, bleeding risk, as well as drug failure. And the majority of thrombus arises in the left atrial appendage, more than 90% in patients with AFib. And this idea that, with surgically, if somebody goes for open heart surgery, you can take, suture, close the appendage, may be a preferable option in some patients who are either intolerant or high risk for anticoagulant therapy. And there are several studies to this, and I'll skip through this just in the interest of time, but the treatment options are obviously anticoagulation, which is the most common, well accepted, reasonable data behind it, but there's been several trials now with closure of the left atrial appendage for embolic protection. And as these trials were going, at the same time, there's been changes in anticoagulant therapy. There are newer oral agents that may be better in terms of reducing ischemic events, as well as with having lower bleeding complications. They have a shorter half-life. They don't have the same monitoring issues, and so the data that have been collected with left atrial appendage, which I'm going to show, is really related to comparison to warfarin. However, whether this data is the same or not with these newer anticoagulants is not clear yet. But regardless, there is no free lunch. Anything that's going to prevent clots, any antithrombotic, will also cause an increase in bleeding events. It may be less than warfarin, but it still has an increase in bleeding events. The majority of data that we have right now is with the Watchman device. And you see here, it's basically, this video doesn't play, but the concept is it's a nitinol frame with a PET fabric over it. It's done through a transeptal approach from the transvenous access. Transeptal is done, and this device is deployed in the left atrial appendage. Over time, there's endothelialization of the device, and in the majority of cases, although there are cases where you still have residual flow, you seal the appendage. You need to size these devices primarily with TE as well as CT to make sure you adequately oversize the device to seal, and there's different appendage anatomies that are more favorable than others. There are other devices out there as well. They don't have as much data, but their trials are ongoing. In the US, we don't have any approved devices, but in Europe and here as well, there's both the Watchman and the Amplatzer cardiac plug, my understanding, is approved. There's also other approaches where it's a transpericardial from a subxiphoid approach, where in patients that have an intact pericardium, through a technique where you do a transeptal and go transpericardial, you can suture ligate the left atrial appendage. With this approach, there's absolutely no data at this point in terms of outcomes or even results related to this, so I don't really want to focus on this at all. The largest study is with the Watchman device. The initial trials, the main trial I want to focus on is the PROTECT AF trial, which was a randomized trial to warfarin therapy in patients who were warfarin eligible. These were all patients who were warfarin eligible, and with that trial as well, there was a continued access registry. The most recent trial was the PREVAIL trial in the US, same endpoints as PROTECT AF, but a slightly higher risk patient population with a CHAD score of 2 or greater. And the PROTECT AF trial was a prospective randomized trial, 2-to-1 randomization, left atrial appendage closure to warfarin control. All patients were candidates for warfarin therapy, and basically the primary efficacy endpoint was a composite endpoint of stroke, cardiovascular death, or device embolization. The primary safety endpoint was device embolization or bleeding. And the long-term results you see here, the odds ratio was 0.6 in favor of Watchman, and for non-inferiority, the device was effective, and this was at 1,500 patient years. And they're in different subgroups. Almost all of them favored closure and overall. And even in patients that were high risk that had a prior TIA or stroke, there was benefit. In terms of the efficacy endpoint here, you see a reduction in hemorrhagic stroke, but no difference in ischemic stroke here. but no significant difference. But there was a marked reduction in hemorrhagic stroke, which is related to the fact that oral anticoagulants increase the risk of bleed. And cardiovascular death was lower as well. Now, this was the most recent data that was released at the Heart Rhythm Society, and this is what most people have been talking about. At 5-year follow-up, there was a mortality benefit with left atrial appendage closure compared to warfarin therapy. A lot of things we do in cardiology haven't shown mortality benefit, and it was surprising. And but basically, the issue is with the device, you take an upfront hit related to the complications of the procedure itself, whether it's pericardial effusion, air embolization, stroke. But as you get longer and longer follow-up, the complications related to long-term anticoagulation are overwhelmed the initial procedural complications related to the device. So at 5-year follow-up, there was a mortality benefit with the closure of the appendage. And when you look at the cause of death in the majority of these patients, you see here, the only one that's really different is in hemorrhagic stroke. The primary safety endpoint, this is what I was just mentioning, you see there's the initial hit related to the procedure, and the majority of complications are pericardial effusions, embolic events, as well as left atrial injury. But as you get longer term follow-up, the events related to anticoagulation catch up, such that there's no difference in the primary safety endpoint between Watchman or warfarin therapy. And when you look at the events here, you see here the procedural complications related to the Watchman group, the pericardial effusions 4.8%, were the major complication, and then with late events, the major bleeding was the main one, and you saw that especially higher in the warfarin group. Now, this was a trial done with a lot of centers that didn't have experience initially, and so you're talking about a new device, and there's a learning curve as well. So I think that contributed to some of these early complications. So basically, this trial showed that therapy with left atrial closure was superior to warfarin in terms of reduction of stroke, cardiovascular mortality, and all-cause mortality. And the safety event rates were similar. There was an early event rate with the device, but this caught up with the closure. And this was the first study that demonstrated this, and it's important, and it's the only device with that much data out there. There were studies much older from the Plato device, but that did not show this. That showed a trend towards this, but never reached numbers and significance. So, a lot of this early concern was these procedural complications, and that was why the FDA didn't approve this device in the US. The pericardial effusion rates, the embolic risk, and so the question is, with further experience, are these risks less or lower? And so there was a registry after the randomized trial, and you see that implant success went from 89% to 95%, and the procedure time decreased. So with experience, the physicians got better. Complications also decreased. Procedure and device-related adverse events were less than half of what they were in the randomized trial. So as anything, with the experience, the complications got less. So, I'll skip through this in the interest of time, but I think that's one of the key things. Still, the FDA in the US did not approve this device, although there's a fair amount of evidence, and hopefully we'll have this. The FDA panel recently met and recommended approval with this device, but they wanted another trial looking at these complications. That's what the PREVAIL trial was. It was, again, a 2-to-1 randomization, but a lot of it was to see what are the safety hits, what are the safety events. And so they required that a significant percentage of the sites be novices. So they wanted to see, is this translatable? And they also picked a slightly higher risk patient population with a CHAD score greater than 2 in the majority of patients and an average CHAD score of 2.6. And they allowed patients that had indications for clopidogrel in the trial as well. And they had multiple endpoints. And the first was this sort of look at the safety endpoint. And they looked at 7-day occurrence of death, ischemic stroke, embolization, or procedure or device-related complications. And then they had a late endpoint, 18 months comparison composite of stroke, embolization, and cardiovascular death, as well as looking at late endpoints of ischemic stroke or embolization after the 7-day procedure results. So randomized 407 patients, 2-to-1 randomization. The procedural success continued to increase from the PROTECT AF trial, and complications decreased from that original trial. So even in a trial where there were a lot of new sites that didn't have experience, because of the original group experience with this device that was translatable, the subsequent trials show reduction in safety events with further experience. And you see a dramatic reduction in pericardial effusions that required surgical repair. And the primary safety endpoint was met compared to, in terms of the secondary endpoint of 18-month efficacy, it didn't quite meet the upper bounds for non-inferiority. But very few of these patients here had met their 18-month endpoint. So the same as you saw in Protect AF, I think with continued follow-up, we'll see it. Everything's on the right direction. We just need to have more continued follow-up. The third endpoint, which was looking at late events after 7 days and before 18 months, it did meet its endpoint for non-inferiority. So again, it showed, despite using a higher risk population with a CHAD score of 2, it showed a safety and efficacy in terms of warfarin therapy. I won't go through the Amplatzer plug. There's no randomized data with it. It has CE mark. It's available
Excuse me,
here as well.
doctor, time is up.
Okay. So I'm just going to just finish with here. I think it is alternative to long-term antithrombotic therapy. It's superior to Coumadin at long-term follow-up, and the procedure is translatable with new operators, and it should become the standard of care in patients with AF. Thank you.